The Addiction Podcast, Point of No Return.
Hello, everybody, and welcome to the Addiction Podcast, Point of No Return. My name is Joni Siegel, and this is episode number 235. Just a reminder before we get into our interview today to please subscribe to this podcast wherever you listen to podcasts, and also give us a good rating so that more people can find our podcast. Also, if you could check us out on YouTube, we've got a YouTube channel by the same name as the podcast, the Addiction Podcast, Point of No Return. And if you could subscribe to our YouTube channel, give us a thumbs up, and also ring the bell, you will be notified when we put up new videos, which is every week, Thursday at 6 p.m. Eastern Time. So today we have an interview. Now, this is a little bit difficult. This is a little bit different because we have been, interviewing people who have their own history of drug addiction. And today we're going to be talking to a gentleman named Dr. Stephen Gelfand, and he is a board-certified rheumatologist with over 40 years clinical and teaching experience. So he's going to bring a little bit of a different take to our conversation about the opioid pandemic. Let's talk to Dr. Stephen Gelfand. Dr. Gelfand, thank you so much for being willing to be on the podcast today and talking to us. You have a different perspective. I'm excited to hear what you have to say.
Yeah, I'm glad to be on the podcast, and I'm very glad to give you my perspective, which, goes back quite a few years, to my training in the starting from the 1960s. And I think it's important for for everyone to hear what really went on in medicine, prior to the opioid revolution and the opioid epidemic.
I completely agree. Do me a favor, just start back with your background, like where you grew up, how you got into the medical field, what was your goal, what were you working to do when you got started?
Yeah, well, I always had a desire to go into medicine and become a doctor. And so, I really went through, traditional medical circles in regard to my medical training. After my medical school, which was at Albany Medical College at Union University, New York, I was a resident in internal medicine at Long Island Jewish Medical Center in the late 1960s and early 1970s. And after that, I went into the Army for 2 years, which was during the Vietnam War, as an internist and the head of medicine at the U.S. Army Hospital in Redstone Arsenal, Alabama. And then after that, I took a NIH fellowship in rheumatology at the University of Tennessee in Memphis. And subsequent to that, I did rheumatology and internal medicine in Southern California for about 20 years. And then after that, I did mostly rheumatology for about 22 years in the South.
Okay. Now, Dr. Gelfand, just because I'm a slightly bit uneducated, what is rheumatology? What does that mean?
Rheumatology is a subspecialty of internal medicine. You have to go through an internal medicine residency before you can become a rheumatologist. And rheumatology deals with the diagnosis and treatment of many types of different types of chronic non-cancer pain, such as arthritis, fibromyalgia, low back pain, all of these conditions which have been mentioned, during the opioid epidemic. So
you're almost like the precursor to like a pain management doctor, because you get at the root of pain, right?
I'm not a pain management doctor, but pain management is an important part of rheumatology. But there's a lot of aspects to pain management, in addition to just medications, which, I'll talk about in, just a minute or so.
Okay.
Rheumatology, we diagnose and treat different types of arthritis. We also fibromyalgia, which is a very common type of chronic pain, low back pain, and there are a number of conditions that we treat in which pain management is one aspect of treatment, such as when we treat rheumatoid arthritis, we have specific drugs that we use that decrease the inflammatory process. And even though we do use pain medicines, particularly NSAID pain medicines, and in very selective cases, we may use opioids. So I just want to say that I'm not against the use of opioids in very selective cases.
But it has to be controlled, and it can't be
Definitely.
overprescribed. And I know you're going to talk about that because
Right,
that's basically what we're looking at today. Just out of
right.
curiosity, have there always been some form of opioid? Has it always been a solution for pain?
Well, like I say, we have used opioids in certain cases of, say, patients who have very severe arthritis, end-stage arthritis, like with bone on bone, and are in a lot of pain and have been refractory to other types of conservative treatments, and particularly have not had a history of significant substance abuse or significant mental health issues. In those cases, we do use opioids, which have been beneficial, but again, the opioids have to be closely monitored,
Right, right.
And so, but most cases of rheumatology really don't require opioids, and we have a number of other types of treatments that are very effective for reducing pain and improving function. Actually, this was brought out in the 1980s by the Arthritis Foundation. There was a particular a doctor, I think she was a PhD in nursing at Stanford University, Kate Loring, who developed the Arthritis Foundation self-help programs for both arthritis and fibromyalgia, which incorporated a number of exercises as well as the importance of stress management. And she developed Arthritis Foundation self-help program for arthritis, Arthritis Foundation self-help program for fibromyalgia, as well as the PACE exercise program, which is people with arthritis can exercise, and the aquatic exercise program, which has been very beneficial for many patients with arthritis. So we've been, turning to these. They're really considered what we call self-help, multidisciplinary programs, that we can, refer patients for, and they really help in regard to reducing pain and improving function, beyond just what we can do with medications.
Understood. So you had obviously years of practice where there were a lot more solutions, if you will, that you were employing besides opioids. What led up to you kind of realizing that maybe there was a situation with opioids?
Okay, well, to really answer that, I have to go back before my training in rheumatology to when I was a medical resident in New York City in the late 60s and early 70s. It was during an earlier heroin epidemic in New York City during the Vietnam War. And when I was a medical resident, I was taking care of some of the most complicated cases, medical complications of heroin. And I developed an appreciation of heroin, on both its devastating effects on both the body and the brain. Actually, heroin is very similar to morphine. It's actually diacetyl morphine, and it's a semi-synthetic product in which which is derived from the acetylation of morphine. Morphine is a natural product of opium. So I developed this understanding of what opioids, particularly heroin, can do, and also not only the body, but the brain, because it can affect so many different areas of the brain in regard to pleasure and emotions and pain perception, and also breathing during sleep. And, later on, this was all experimentally confirmed by the discovery of mu opioid receptors, natural opioid receptors in multiple areas of the brain. And also during this time, they were developing pilot programs for the use of methadone to treat heroin addiction. This was in New York City when it was just starting. And also, interestingly, the FDA in 1971 approved the use of naloxone or Narcan to reverse heroin overdoses.
Did you just say 71?
In 71, right?
Wow.
They used
I had
it
no
in-
idea. I had no idea it's been around
Right.
that long. Sorry.
Right, they used it in an IV and IM form. It was later on developed as a, intranasal form. But yeah, I mean, all this started in the early 70s, So I really had an appreciation. And like I say, once the, opioid revolution started with OxyContin, I was just, totally taken back by what they were doing. But, I'll get to that in just a few minutes.
Yep. It's interesting, just an editorial comment on what you say about, heroin and the heroin epidemic. A couple years ago, we interviewed the former drug czar of the United States, and he said the same thing. He said, drug addiction epidemic is not new. We had heroin, and heroin was a huge epidemic. This is the whole OxyContin and that form of opioids is now, in front of everybody's mindset, if you will. But, there was addiction way back then, and
Right, and
you
then
bring that up.
When you consider that even 100 years before that, we had a terrible problem with soldiers and veterans becoming addicted to morphine given for pain during the Civil War. And in the early 1900s, we had another heroin epidemic from, heroin, which was manufactured as a cough suppressant by Bayer Pharmaceuticals in the early 1900s, which, was then later taken off the market. So we certainly had a background history in, heroin and opioids.
Right. Exactly. Okay. So now bring it forward from there a little bit.
Right. And just one other thing I briefly might like to mention, during the same period of time as the heroin epidemic, when I was a resident in New York City, we had another drug epidemic, which I'd call the Valium epidemic. Valium was a minor benzodiazepine tranquilizer, which was unethically marketed for really a number of everyday conditions of tension, stress, and anxiety, especially to American housewives.
Right.
And the drug, can result in dependency and addiction. And this was actually, broadcast by the entertainment industry. I don't know if you may be too young to remember this, but the Rolling Stones had a little song called Mother's Little Helper.
Yes. And it was a little pink pill, wasn't it?
Right.
Wasn't Valium like pink?
Right.
Yeah.
Right.
Yeah.
And then they had another, there was a movie called Valley of the Dolls, which, referred to the Valium epidemic.
Mm-hmm.
And, expanding this to how this was marketed, it was marketed by a physician by the name of Arthur Sackler. Arthur Sackler was one of three brothers.
I was going to say, why am I not surprised, Dr. Gelfand? Right. Sorry for interrupting, but why am I not surprised that the Sacklers had a hand in the Valium marketing? Right. I will be quiet now.
He was one of he had two younger brothers, Mortimer and Raymond. They were all psychiatrists, and they all did research at Creedmoor Mental Hospital in Queens, New York. And they certainly understood the effects of substances on the brain, you know. And obviously, when he marketed Valium, I mean, this was what really got it to take off as far as a commercial success, because so many, you know, people, and particularly women, became dependent and addicted to this and went back to their doctors to continue to ask them for continued prescriptions, you know. And so Arthur actually turned from doing psychiatry, he went into medical marketing and medical journalism. And this is where he made his great fortune. And he was actually elected to the Medical Marketing Hall of Fame. And then his younger brothers, Mortimer and Raymond, you know, they subsequently founded Purdue, first Purdue Frederick and then Purdue Pharma. And then they used these same marketing techniques to get OxyContin, which was an extended release form of oxycodone, another potent opioid, off the ground. That was actually directed by Raymond's son, Richard Sackler, who was the you know, driving force behind the commercial success of OxyContin. You know, so you know, basically what I'm trying to do, I mean, all this is known. I'm not giving, you know, anybody any new information or giving you an opinion. All this is known. All I'm trying to do is remind people of the past, and I'm trying to clarify this by connecting the dots, which I think we need to all be aware of.
I think you're absolutely right. We've had other people talk about Purdue, and we had a gentleman, an author named Gerald Posner, who went back and researched all of this. And yeah, I'm glad that you're bringing it up again, because I think most people don't know it. And I think that sometimes there's a lot of attention just on what's happening right now, but it's been here for a while. So I like it. I like it.
Gerald wrote a great book, you know,
Yes.
Farmer. You know, I've corresponded with Gerald. And of course, you know, the more recent book, Empire of Pain by Patrick Radden, you know, Keefe, you know, basically the history of the Sacklers. But there were other books, Dope Sip by Beth Macy. And, you know, she was, that's the book that's going to be on Hulu, you know, when that series starts next month. Yeah. And there's multiple other books that have been written. Dreamland by Sam Quiones and Bad Medicine by Charlotte Bismuth. And I corresponded with all of them. So a lot of this, they really helped in really, you know, solidifying and connecting all these events.
Yep. Okay, so you had the Sacklers marketing Valium, and then bring us forward from there.
Okay, so this is, you know, after I spoke about the Arthritis Foundation programs in the 1980s that we were, you know, and then in the 1990s, there was also a movement in what we refer to as mind-body therapies, which were really devised to reduce stress by a variety of relaxation techniques, which can include meditation. And there were multiple books written in the 1990s about this by some famous physicians. Actually, I just mentioned two, Herbert Benson, who was a cardiologist at Harvard University and later established the Mind Body Medical Institute at Harvard. And then there was John Sarnow, who was head of physical medicine at NYU. And then they wrote books on this. And this also helped in regard to the importance of incorporating patients in this area. You know, reducing stress became an important part of what we call mind and muscle movement management. In other words, we pay attention to the mind through education, through stress reduction with relaxation, for behavioral techniques such as the use of cognitive behavioral therapy, maybe psychological counseling in those who need it, and a variety of exercises which can actually be started by, say, a physical therapist. And, you know, usually a comprehensive exercise utilizing stretching, strengthening, aerobics, And all of this is very important in the, general management of patients with chronic pain. And
Interesting. So it's not,
so this,
doesn't have to be a pill every
right.
time.
So this is another thing that, we was very well known in the 1990s. And then, here we are in 1995 when OxyContin was first approved by the FDA. And it was really hard for me to believe what they were saying. There were, multiple false claims were made by Purdue Pharma that it was safer than other opioids with a much lower rate of addiction, while it's effective for chronic pain long term. Whereas most of the research studies were less than 3 months for conditions which were chronic. And unfortunately, the medical community bought into these false claims, and they broadly and non-selectively started to prescribe OxyContin and other opioids as well. It was really an easier and timely way of treating patients with complex chronic pain conditions. Just give them a prescription rather than talk to them about all these other issues that may be going on.
Yep. And I believe you mentioned that kind of created some conflicts for what you were doing as a rheumatologist and the primary care, because you knew more.
Right. It did. It was like I was the odd man out. I was trying to, I did a lot of consultations for primary care doctors. And I saw a lot of these patients who are dependent or addicted to opioids. And when I send them their consultations back with a recommendation that, that they either try to taper patients off these drugs or get them into addiction treatment program, they weren't too happy with that, to tell you the truth. So it resulted in me changing a number of practices throughout the years, And then I'd also just like to say that, with all the OxyContin that was flooding, the community. It was getting into multiple medical cabinets and into the streets, and as you know, it became an easy method for teenagers and young adults, to get their hands on it and to either experiment or take it for recreational use, thinking that it was safe because it was prescribed. And of course, this contributed to the mounting toll of addiction and death, which we all, are familiar with. And the other issue was that there was an increased frequency of mental health conditions in many patients with chronic pain, particularly in rheumatology, in this common condition called fibromyalgia, and as well as non-structural low back pain. And the mental health conditions themselves can, particularly depression, anxiety, PTSD, they can generate and they can amplify, chronic pain.
You are listening to the Addiction Podcast, Point of No Return. For more information on the podcast, or to reach out if you have a story you would like to share with us, go to our Facebook page by the same name, or you can email us at theaddictionpodcast@yahoo.com, or go to our website, theaddictionpodcast.com, or call us at 727-314-7080. And please remember to subscribe to our podcast wherever you listen to podcasts and give us a 5-star review. Sometimes the hardest thing about getting someone into recovery is getting them to agree to treatment. Bobby Newman, a certified drug counselor with 30 years experience and an over 85% success rate as an interventionist, has created a series of 12 videos that you can use right now to learn every step to get your loved one to agree to treatment. Call 1-833-918-0008 today and say the word podcast to get a 10% discount. Or go to newmaninterventions.com and type in the word podcast for a 10% discount. This service comes with a free 1-hour consultation with Bobby.
We know that emotional distress, can have physical or somatic correlates, and OxyContin and other opioids were being prescribed for these kind of patients with with disastrous results in many cases, because patients who with these mental issues are very prone to become addicted and to overdose.
Right.
So this was the background, and then my other experience was when I first started a rheumatology practice in Myrtle Beach in 2001.
Okay.
I had joined a group in rheumatology, and when we came into Myrtle Beach, we became very aware of a practice called the Comprehensive Pain Clinic, which was actually one of the first pill mills in the nation, which was in Myrtle Beach. And the doctors in that group who believed they were doing the right thing, but they were dishing out OxyContin and other opioids to just anybody who walked through the doors and complained of pain. And this was actually attracting many people with addiction from various adjoining states, around that area of South Carolina. And,
well, yeah, because Florida became number one in terms of pill mills.
Right. This was actually before the Florida pill mills. And when I first came into Myrtle Beach, one of the first things we noticed, my wife and I, was when our realtor was located in the same strip mall as this comprehensive pain clinic. And we basically had to fight our way through all these people who were just hanging around the strip mall between the cars, just waiting to get in. So we knew right away that this was a problem. And this was actually exposed publicly by an article in the New York Times at the time by Barry Meyer, who was a journalist. And he wrote about this comprehensive pain clinic, and also the Purdue drug rep who was promoting OxyContin to all the doctors in the community. And actually, this drug rep became the highest OxyContin salesman in the nation, And I had an experience that he came into my office one time, and he was trying to convince me to prescribe OxyContin for my patients with fibromyalgia. And I automatically knew he didn't know what he was talking about. And I dismissed him, and I vowed never to see a Purdue drug rep again. But I thought that other people would, other doctors would feel the same way, but obviously they didn't. Right. And so they played right into this. And so, this had a big effect on what was going on. And I actually wrote a commentary in 2002, which appeared in Medscape Rheumatology, which talked about the dangers of prescribing opioids, especially for, chronic pain related to conditions like fibromyalgia and mental health issues.
In 2002, you wrote that.
This was 2002, right. And then I wrote a number of articles for the local paper and the health magazines. And then over the years, I've written multiple other medical publications. And I also wrote letters to the FDA and also to two federal judges in regard to the two trials of Purdue. And then I made contact with a number of, I became a medical advisor actually for a number of citizen advocacy individuals and groups, and this goes back 15, 20 years ago. And I can't list all of them here, but some of the early ones included Ed Bish, who, you interviewed.
He's been on the podcast.
And, he devised oxyabuse.com, which posted those tragic stories of so many people with their experiences with OxyContin. And then he also, formed RAP, or Relatives Against Purdue Pharma. And other ones included the Van Ruyens from California, Barbara and Kirk, who wrote an FDA citizens petition in 2005, trying to restrict the use of OxyContin just to severe pain and not to moderate pain. which the FDA stonewalled. I contributed to that petition, and also others. That I'll just mention is Pete Jackson and Ada Thompson of ARPO, which was the advocates for the reform of prescription opioids, and Larry Goldblum, who was the host of Prescription Addiction Radio, which I appeared on a number of times. And there were multiple others. And then through this advocacy group, they introduced me to Andrew Kolodny, who was very interested in this area. He was an addiction psychiatrist in New York, and he was one of the co-founders of PROP, which was, which was Physicians for Responsible Opioid Prescribing, which I became an original member of.
I was just going to ask you to tell us about PROP and how that came about.
Yeah, well, that's, through this group, I met Andrew Kolodny, and, it was devised first, to educate physicians, because we felt that physicians, needed this education in regard to, this problem with opioids.
And I'm just going to say the name of it. It is Physicians for Responsible Opioid Prescribing.
Right. And they had a lot of, we've had a lot of positive accomplishments over the years. In addition to, education of physicians, public and government approaches, they've contributed to legislation, such as the upscheduling of hydrocodone combination products, and, expanding addiction treatment for the use of buprenorphine, expanding the use of naloxone, revising the pain management standards of the Joint Commission and CMS, which actually encouraged opioid overprescribing. And they also contributed to the 2016 CDC guideline, primarily for primary care physicians, which emphasized, a different perspective in regard to the treatment of chronic non-cancer pain, particularly from a biopsychosocial perspective, and particularly in opioid naive patients who had not started on OxyContin. And this had a lot of similarities to some of the things that I was very well aware of earlier on in regard to mind and muscle, multidisciplinary management, which did not involve, specific drugs. So all these things were important that they were involved in. And they also had, the guideline also contained gradual tapering guidelines for OxyContin, reduction of high opioid dosages, and a shorter duration of opioid treatment for acute pain. Well, some of this was controversial because there were, many, particularly primary care doctors, misinterpreted these guidelines, and then they had these patients who were dependent on opioids, and they too rapidly tapered them off opioids, resulting in withdrawal reactions, and that became a major, bone of contention. But the guideline never suggested rapid tapering; they suggested gradual tapering, and also the use of buprenorphine, and a referral for addiction treatment as well.
Right.
So,
how big is PROP now, Dr. Gelfand? Has it grown a lot?
Well, it contains a number of physicians. I'm not active in it, anymore. I was active in it for about 10 years. It contains a number of experts, from around the country, including Jane Ballantyne, who was one of the, first pain management physicians in the country that, started to warn, about the excessive use of opioids, for chronic pain. And,
right.
She's written a lot of articles. And we also have other experts, nationally, and there was a couple of doctors from Canada as well. And so it's, I think it's been one physician group that has been, an answer to some of the opioid overprescribing that's gone on. It's been the object of a lot of negativity.
I was going to say, I'm sure that you have run into the teeth
Yeah,
of
yeah,
some
and
vested interest. Like,
right.
did you mention something about the AMA not being super
Yeah,
with you?
well, you know what, the AMA had been, they recently came out with, they have highlighted the fact, and this is well known, that more recently, like from 2011 to 2020, there's been a 40% reduction in physician opioid prescribing,
Okay.
which was good. And there's also been an increased use of the state PDMPs, or prescription drug monitoring programs, since 2014. There's been a marginal increase in prescriptions, for buprenorphine and naloxone, although almost 4 million doses of naloxone have been distributed, by harm reduction and other community-based organizations. And they've advocated for improved care for patients with pain, mental illness, and substance abuse disorders. However, they have really, in my opinion, they have really downplayed the role of physician overprescribing in causing opioid addiction and overdose deaths, and appeared to be more concerned with providing access to opioids and elimination of the opioid dosage thresholds of the 2016 CDC guidelines. And they said absolutely nothing about iatrogenic addiction as the important link to illicit fentanyl deaths, which we have a horrific problem of going on right now. And, that's, and they've also been not really done hardly anything in the importance of what I mentioned before, of diagnosing and differentiating between the different types of chronic non-cancer pain, which has always been a problem for many primary care physicians, And, these are the common types of pain that respond to non-opioid multidisciplinary management as first-line therapy, which, I previously discussed, and which have been, recommended by the, CDC guideline, So, the other thing I remember is that, about over 10 years ago, the AMA was running full-page ads for OxyContin in the AMA news, for months,
Wow.
So, and this was about 10 years ago.
Wow.
So
wow.
So, I think it's a two-edged sword, but I don't think the problem with the AMA is that they haven't really, haven't really dealt with some of the important issues that I just mentioned, as far as, the link of prescription opioids to illicit heroin and fentanyl. I mean, we know that this is well established that 4 out of 5 heroin addicts first started with prescription opioids. And
Right.
so they really have tried to they try to separate both the prescription opioid and the illicit opioid epidemics. And they really haven't done hardly anything as far as trying to encourage doctors to learn more about chronic non-cancer pain.
It is difficult, I think, to look at oneself and what, oneself might be responsible for. And that is likely what, happens there.
Yeah, I know. I mean, like I say, it's it's been a problem. It's just, one other thing I did want to mention, before we go, is I just wanted to, say something about the false claims in the marketing of OxyContin that were made by Purdue Pharma, and this is very important because they made a whole series of false claims, that, changed medical beliefs and practices and got doctors to overprescribing, opioids for many patients, which actually ignited the opioid epidemic.
Yep.
And some of these included like the false claim that opioid addiction is rare in chronic pain patients, which was not true. There's often a close relationship between pain and addiction, and pain can be very complex and have psychosocial correlates and psychological aspects. And this actually, what it did was it encouraged doctors to ignore addiction and just concentrate on chronic pain and to continue opioid prescribing, where a lot of patients really needed to be referred for addiction treatment. And Purdue Pharma and its many opioid advocates, including the FDA, they grossly oversimplified chronic pain. They often lumped both cancer pain and chronic non-cancer pain together, while they downplayed and limited the definition and the spectrum of addiction. And actually, the frequency of addiction, another term for it has been opioid use disorder. That was brought out a few years ago in studies from the Geisinger Clinic in Pennsylvania, where they found that there was over 40% lifetime incidence of opioid use disorder of varying degrees in chronic pain patients on chronic opioid therapy. And so this was, already brought out in the in research studies. And the other thing was that, and I'm sure you've heard about this, there was a tendency to blame the victim for addiction, which started with, what Richard Sackler was telling his drug reps.
They didn't use it properly. They didn't use the drug properly.
And they said, and then they actually called them, if they say anybody who took OxyContin with chronic pain and became addicted, he said they were nothing but reckless criminals. And this was all very well documented by, particularly in some of these books, and also by the Attorney General of the Commonwealth of Massachusetts in her complaint. So this is important to realize. The other thing that they stated was that opioids were safe and effective for chronic pain and are the gold standard. Now this was something that there was no evidence for that in the medical literature. That I reviewed this subject, back in 2006, and there was no evidence. There was actually a lack of evidence of long-term safety and effectiveness for opioids in chronic non-cancer pain. And I actually debated this with a leading proponent of opioids, a Dr. Scott Fishman, who was director of pain management at the University of California, Davis. And I brought up all these, studies which did not show what he was claiming as gold standard. And the same approach was later reached a few years later. It was updated in a 2015 systemic review from the NIH and the Annals of Internal Medicine, which were then incorporated into the 2016 CDC guideline. So that was another big mistruth that was being circulated in the medical community. Also, opioid therapy can be easily discontinued, which was not true. And there was, of course, you probably heard about, opiophobia and pseudo-addiction concepts, which did nothing more than encourage physician overprescribing and also raising opioid dosages to dangerous levels. So all of these things were, were major areas that were being broadcast to the medical community particularly during these early years, which got the opioid epidemic, ignited and subsequently exploded.
Yep. I think we can agree that the marketing practices of the Sackler family were unethical at best, and that there should be there should be penalization on the family as well as the executives of the company, and whether we will see that or not remains to be seen, but it is obvious, I think, to us here at the podcast and to probably anybody who's listened to this podcast that they are responsible. The Sacklers are responsible. I didn't realize they were responsible for the Valium epidemic, but there you go. So this has been their practice for decades. And yeah.
I think the common thread is that they were dealing with, drugs which were psychoactive and could lead to dependency and addiction. Like I said before, they affected the brain,
Yep.
But this was their ticket to tremendous commercial success.
Yep.
Which is how they made their fortune, basically.
Yep. They knew it and they profited off of it, and therefore they should be penalized for that, as I say. Whether they will or not, I don't know. Dr. Gelfand, I really appreciate all of the work that you've done. If someone wanted to contact you and either get you on their podcast or maybe get you to write something for them, how would they do that?
Well, the best thing is just email. You can email me. It's, sgelfand42 at gmail.com.
Perfect.
Okay.
Thank you so much for taking the time to talk to us today. I really appreciate it.
Okay, it was my pleasure, and I hope that people listening got something out of this.
I am sure they did.
Okay, thank you.
Thank you for listening with us today. I hope that you got something out of Dr. Gelfand's interview. He has been around this whole addiction pandemic for decades, and I personally had no idea that Valium was an epidemic. I obviously knew about Valium, obviously knew about heroin in Vietnam and what occurred there, but had no idea about Valium. Also had no idea that Richard Sackler was responsible for the Valium epidemic. And I wish I could tell you that I'm surprised, but I'm not. They are a family who has profited on this whole addiction pandemic, and they have protected their profits. And I wonder how they sleep at night. But that's our interview for today, and we'll be back again next week with another interview. So please join us again. And if you or someone you know needs treatment, please reach out. Don't wait. It's not going to go away on its own. You have to actually do something about it. Have a good one.
You have been listening to the Addiction Podcast, Point of No Return. For more information, reach out to us on Facebook or go to www.theaddictionpodcast.com. Our email is theaddictionpodcast@yahoo.com.